Well, it's 3 o'clock, so I guess we should go ahead and get started, make sure we have enough time. Thanks so much for joining us for Core Competencies for the Emerging Specialty of Pain Psychology, hosted by the Society for Health Psychology's Pain Psychology Interest Group and co-sponsored by the Society of Clinical Psychology, APA Division 12. I am Claire Conley, Virtual Programming Editor for the Society. Before we begin, we have a few items to share. First, as you can see, this event will be recorded. So anyone who speaks during it, for example, to ask a question, is agreeing to be recorded and is granting permission for the recording to be posted on our website. The webinar is also eligible for 1 continuing education credit under the Society of Clinical Psychology Division 12 sponsorship. CE evaluation information will be sent via email shortly after the webinar. We will leave the evaluation open until April 2nd, 2021, and CE certificates will be sent via email within 5 to 10 business days after the evaluation period closes. Questions will be taken at the end of the presentation, but you can submit them during the presentation using the chat feature. And I'm going to turn it over to Dr. Kearns to begin the presentation. Thank you.
Good afternoon, everybody. I think it's afternoon everywhere in the US at least, well, except for Hawaii, maybe. Welcome. Thank you very much for joining. I want to begin by thanking Claire and also Barbara Keaton from Society for Health Psychology for their organizational efforts bringing us together, frankly, even the invitation to speak with you today. It's a great privilege and honor for us to join you today, and I hope that this presentation by myself and my colleagues will at the very least stimulate some important discussion among our community, within our community, to advance the ideas behind what we're trying to present today. By way of further introduction, I'm Bob Kearns. I'm a clinical health psychologist based at Yale University and affiliated with the Yale-affiliated VA Medical Center, the VA Connecticut Healthcare System. I'm a past president of the Society for Health Psychology. I was a long-standing member of the executive committee and the board of director, including a role after I left my president's role. I had a terrible condition called fear of missing out, and I self-nominated for election again as a member at large. And at that time, the members at large all had to specify some goals or objectives for their term on the board. And mine was essentially to advance the ideas that we're going to be presenting today, which is the concept of pain psychology, to promote promote attention within our community, if not ultimately the development of a specialty or subspecialty in this important area. And I'm going to be joined today by 4 great colleagues who represent diverse backgrounds and perspectives on this issue. We came together under the leadership actually of Laura Wandner, who I will introduce first, and after I speak will be our first speaker. Laura is a program director at the Office of Pain Policy and Planning at the National Institute of Neurological Disorders and Stroke, NINDS, within the National Institutes of Health. She's a former trainee of mine, so I'm quite proud of her career development and advancement. She manages programs within the Acute to Chronic Pain Signature Program and the Helping to End Addiction Long-Term Initiative. Laura continues to treat chronic pain patients at Walter Reed National Military Medical Center. Also joining me today is Dr. Sylvia Malcore. She's a licensed psychologist in Michigan. She is board certified in clinical health psychology, and she has interest in pain management, pre-surgical psychological evaluations, and coping with health conditions. Also joining us today is Dr. Amir Ramezani, a psychologist at the VA Whole Health Mindfulness Center and a teaching faculty at the University of California, Davis. He enjoys building professional communities and has held multiple educational leadership roles, including serving as the former president of a tech and neuroscience organization, founder and former chair of the SVPA behavioral medicine and neuropsychology section, and a former training director at the University of California, Davis. And finally, last but not least, is Dr. Ravi Prasad. He's a psychologist by training and currently a clinical professor and director of behavioral health in the Department of Anesthesiology and Pain Medicine at the University of California, Davis School of Medicine. His clinical work focuses primarily on evaluation and treatment of individuals suffering from acute and chronic pain conditions. He's actively involved in leadership activities in regional and national organizations through which he has been involved in interprofessional core competency, curriculum and program development, lobbying for efforts to change policies related to psychological care, and translation of research innovations into clinical practice. Outside the realms of pain, he has an avid interest in clinical wellness and led efforts to implement associated initiatives in multiple healthcare settings. And Ravi also was the founding chair of our Society for Health Psychology Special Interest Group on Pain Management. With that, let me see if I can advance my slides. Uh-oh. So our objectives today are to articulate the rationale for developing pain psychology core competencies, to develop familiarity with the 4 pain competency domains that'll be the main structure for our presentation today, and describe why understanding core competencies is important for any psychologist, regardless of their specialty. Why is pain important? Pain is viewed by many, including myself, as a significant public health crisis, with a focus specifically on chronic pain across the continuum from acute pain to chronic pain management to pain management at the end of life. It's important to acknowledge that, of course, pain is ubiquitous to the human condition, but the number of 50 million represents data from the Centers for Disease Control and that were surfaced during a national health interview survey. And it's important to acknowledge that 8% of US citizens, or half of those who suffer from chronic pain, experience pain that interferes with their functioning and emotional well-being on a daily basis for half the days over the past 6 months. So that's the operational definition. In addition to its high prevalence and significant effects on people's lives, pain can be considered a public health crisis due to its high costs. It's been estimated that literally the United States spends $500 billion every year on pain and pain management in direct and indirect costs. If you think about that in terms of the enormous recent bill that was passed for COVID relief, that was 1.9 trillion, this would be about a quarter of just that, to give an estimate of the size. And you all can recognize that from just going to your local pharmacy and seeing the long row of analgesic medications and other devices for assisting people with chronic pain. It's also important to acknowledge that there are significant disparities in the prevalence of pain, and chronic pain in particular, and in care. And it may surprise some of you to know that women, for example, are potentially disadvantaged relative to men, minority and ethnic groups, but other groups like people living in rural settings, people living in poverty, those that were previously employed but not currently employed, low education, et cetera, et cetera. These are significant social determinants that are important for us to attend to. There's also, as already acknowledged, significant emotional distress and often declines in productive and pleasurable activity and overall diminished quality of life. All of this comes to the point where we need to think about this as literally a public health crisis. Of course, the opioid epidemic and the pain epidemic become conflated at times. And in fact, I think the opioid epidemic has only heightened our concerns and attention to the challenge of meeting the pain care needs of citizens, and the importance of addressing poor pain management or under treatment of pain, and the potential role for psychologists in this endeavor. Terms such as pain psychology and pain psychologist are thrown around a lot. They're used in advertisements for new positions at institutions frequently, but of course these terms have no particular status within the world of psychology or within the APA. Psychologists have not taken the lead in defining or operationalizing these terms. Thus, it's been delegated to other professions, and I'm sure virtually everyone on this call would agree that that's not a good state of affairs. And so it's our view, collective view among the presenters today, that we should work to define these terms and then work collaboratively with other disciplines in the further operationalization and use of the terms. It's our view also that pain psychology, to the extent that it becomes a specialty or a subspecialty, people can emerge or come to this specialty from many different perspectives. And you see a list here that probably is not all inclusive. My background is as a clinical psychologist, and then maybe secondarily clinical psychologist. I have a background in clinical neuropsychology. But the people in this field come from many different walks of psychology, parts of psychology, and it's important to acknowledge. Our presentation is going to be informed by a paper that this group published under the leadership of Dr. Wandner in the American Psychologist in 2019, and you should have access to that article. I hope you've all read it and thought about it and come to this presentation today prepared to talk about it. We have structured our American Psychologist article on a previously published framework for thinking about pain competencies regardless of disciplines. And there were representatives, including representatives from this group. I think Amir or Ravi, I can't remember which one, or maybe both of you were involved in that work, led by Scott Fishman at UC Davis. And in that paper we outlined 4 domains that you see here on the slide, and our series of 4 presentations by my esteemed colleagues will address each of these domains. And with that, I'm going to turn things over to Dr. Wandner to begin our presentation. Thank you.
Great, thank you so much, Bob. So I'm going to be talking about the first domain that we identified to be a competent psychologist. And so it's named the multidimensional nature of pain. What is pain? And so in order to be a competent pain psychologist, we feel it's important for a psychologist to understand that pain is multidimensional. So what do we mean by this? I'm going to give a really quick overview and then go in depth in a few areas. So first, pain is complex and multifactorial and individual specific in nature. It's important to understand the relevant and evolving theories of science for understanding pain. It's important to understand the terminologies used to describe pain and associated conditions. And it's important to be able to communicate all of the information I just listed to other medical providers, as well as patients and caregivers. So I want to spend some time going over a few of the theories that a competent pain psychologist should be well versed in when treating pain patients. And really the most important is the biopsychosocial model, which recognizes that the experience of pain is the result of complex interactions among biological, social, and psychological factors. There are other models that also emphasize the role of the central nervous system, particularly the brain, in determining the experience of pain. And so these include the gate control theory of pain, models that emphasize localized pain-brain circuitry, and activation of emotional circuits by chronic pain. And all of these models are informed and reinforced by important observations about the multidimensional nature of pain, including the experience of pain itself and its effects on physical and emotional well-being, and overall well-being and quality of life. Next slide, please. Other important models are the operant theory and social cognitive theory. When applied to pain management, these models really help psychologists better understand the development and perpetuation of factors commonly associated with the adaptation and changes in functioning and quality of life and well-being. And models focused on social and psychological factors are also important because they can impact the pain experience. So some relevant models here might include the fear avoidance model, which can characterize the patient's experience of pain and their engagement in treatment. Also models like the socio-communication model of pain, pain empathy model, and communal coping models can help psychologists better understand their patients based on a variety of interpersonal and social variables, which can improve the therapeutic alliance. Next slide, please. Psychologists can also excel in their practice by becoming aware of different types of pain conditions, their pathophysiology, and common medical and mental health comorbidities. It is really important to be able to stay well-versed in these areas as the research continues to evolve. It's also essential that a psychologist be well able to communicate his or her knowledge using terminology that's understandable by patients, caregivers, and other providers. So mastery of good communication skills is really important to develop a client-centered and team-based approach to care. And I will hand this over now to my colleague, Sylvia.
Sylvia, if you're speaking, we can hear you.
Yeah, good, wonderful. Thanks so much, Laura. I'm going to spend some time discussing pain assessment. So as discussed before, the biopsychosocial model is very important in pain psychology. Pain assessment is multifaceted, and an understanding about each of these domains interact and change over time is relevant. Psychologists may evaluate patients at different time periods over the course of development of their pain, and evaluations can include information from multiple sources and domains. So, obviously the clinical interview, medical record, collateral supports, behavioral observations, testing, measurement. And I think what's relevant here too is to consider, is this information that we're getting, is it appropriate for the population presenting? And we want to be able to identify the multiple contributors that may be impacting the pain experience. Next slide, please. So within pain psychology, given the nature of the work, we're often working and connected to an interdisciplinary team. So even if someone was to be in private practice, you're likely going to encounter patients who have chronic pain. And there may be referral sources or a need to connect with other healthcare professionals. And given there's different tools to assess pain. Patients with pain may be assessed in different ways by different types of providers, and there's strengths and limitations of each of these tools. And even if we're not using each tool, right, it's helpful and important for us to be aware of the potential limitations while also working with these other providers and patients. One thing that I often think of is, it's an older article by Kerns and colleagues in 2005, but it was one that made a really big impact on me, was that they did a longitudinal prospective study looking at individuals with high risk factors for serious lower back pain. And in quote, the development of serious lower LBP disability in a cohort of subjects with both structural and psychosocial risk factors was strongly predicted by baseline psychosocial variables, structural variables on both MRI, a discography testing at baseline only had weak association with back pain episodes and no association with disability or future medical care. And I think that's pretty powerful to hear, right? That it's important to consider, how do we support patients and work with the team regarding patient beliefs and understanding about information received, while also working within our own competency. So for example, many of us have heard patient concerns about their pain condition, such as the patient stating, I have degenerative disc disease, right? And the many thoughts and the many feelings that might be associated with this. So that's where it becomes really important to be aware of where is this information coming from, what's their understanding, what's the language used by other providers, and again, considering strengths and weaknesses of the tools used to evaluate the pain experience. Next slide, please. And then, of course, there's various potential evaluations in which there may be a pain psychology focus. For example, pre-surgical psychological evaluations, which may be looking at perhaps implantable devices that might have the goal of pain management, or there might be procedures in which part of the goal might be by the patient to achieve increased pain management. And these can target associated risk factors and expectations of the patient. There's a wide range of practices, and you really want to consider the literature and the evidence and the purpose of the evaluation. So for example, what exactly is it that you're trying to identify? And potential insurance requirements, I think, is something that can be helpful to consider, because that might be required maybe for spinal cord stimulation, but perhaps it's not required for a surgical fusion. And it can be helpful to be prepared to answer these questions both within teams that you might be working and patients themselves. Next slide, please. And then, of course, other potential evaluations that might have a pain psychology focus or emphasis might be, of course, opioid risk types of evaluations. Now, of course, we've already alluded to this and discussed this, but there's been some pretty significant shifts in views in the approach of opioids. And then, of course, forensic evaluations, so consideration of multiple roles. And then, of course, the evaluation for treatment planning. We understand, in kind of looking at the literature, wanting to consider base rates and numbers for mental health conditions, and so different comorbidities when we have presenting pain. And next slide. And then I think we have discussed this some, and of course there have been disparities in pain management identified across multiple domains. And the literature discussing disparities in pain management could certainly be in its own course, let alone what we're briefly discussing today. So for example, racial, ethnic, gender differences found in the treatment of pain, and certainly disparities in care is especially important when we're considering the evaluation of patient, right? So, when a patient is presenting to us, when we're seeing a patient, we really want to keep in mind a lot of different questions in the context of treatment disparities. So for example, was this patient receiving adequate access to care? Okay, because this is helpful to kind of guide our evaluations. And there have been recommendations for addressing disparities, of course, and this includes improvement in assessment of pain. Again, this is an incredibly important topic, and certainly there's so much more than we're covering today on this. So next slide, please. And this was also touched on briefly as well. Communication in assessment, so communication in general when we're working with patients who have pain. Pain psychologists working with psychologists with pain, likely to be giving feedback and communication to multiple individuals. So certainly feedback to patients, but then also very likely feedback to caregivers and support teams, healthcare providers, and also consideration of the healthcare record, integrated records, and the 21st Century Cures Act. Thank you. And I now look forward to hearing from Amir.
Thank you, Sylvia. I'm really happy and honored to be able to talk about this section. This is the part that we are, as behavioral health professionals, behavioral health in a medical context, we are really looking at how do we actually help individuals relieve pain. And in doing this, we take a slightly different approach where in our decision making, when we're developing the treatment plan, we want to share that with other providers. We want to be able to also consider diverse interventions, which we'll talk about in a moment. And in the paper, we list a little bit more of interventions that are much more inclusive, but we sort of touch on the main ones that we thought would be helpful to share with you. And in our treatment with the patient, we're also managing their risk. As you know, a lot of individuals are having high dose opioids. There could be suicidal challenges. So we're also assessing risk. and our treatment plan is flexible. So that's like the bigger picture as we're approaching how we provide intervention for patients who have pain. And in doing this, we want to identify evidence-based psychological options. We also want to, just like Dr. Malcore and Dr. Wandner was mentioning, we want to bring in other healthcare professionals. And to some degree, we may want to reach out to the physical therapist, occupational therapist, if they're present, or the physician, or have some communication and to really know what other folks are doing. It could be, of course, easier in some settings, and it could be much more harder in other settings, of course. So we also want to consider that. And we want to have an integrative treatment plan that really promotes health, self-management, lifestyle changes. And our treatment plan is really aimed at a holistic approach rather than just our intervention alone. So that's a very important part when it comes to managing pain. As it was mentioned before, disability is a major challenge, and sometimes the lab works don't necessarily predict the disability challenges, and we want to be able to monitor it over time, and whether it's an inpatient or outpatient setting. And so when we are looking now at the interventions, as practitioners, most folks are familiar with CBT. There's a lot of evidence for CBT being able to manage disability. In some situations, the functional aspects of severe chronic pain, as well as the emotional elements that comes along with that. But we also want to think about other approaches as well. We want to have diverse treatment approaches. Third generation approaches, which really there's been a lot of development in this area, I would say, in the last 5-6 years. Acceptance and commitment, a therapy where we're really looking at how the pain is taking away the person from their values and their core belief, their core values that drives them and brings them meaning and joy. Mindfulness approaches, mindfulness-based stress reduction, really gave rise to a lot of interventions that really are evidence-based and really has been shown to support individuals with chronic pain. One of them being mindfulness-based cognitive therapy. Mindfulness-based stress reduction itself has been studied over time for many years as well, where we're really helping the individual to de-identify from the pain, be able to observe in a way where they're not consumed by their pain, so that their life is not consumed by the pain, so that they could function in their life. And then consider direct emotional expression interventions, which are, I would say, for example, with emotional awareness and expression therapies, is a little bit newer and evidence-based, but really looking at how the emotions can really worsen the pain and intensify, and provide a way in which that emotion can be allowed to be experienced without the resistance and the avoidance. And a lot of these third generation and emotional expressive interventions are really geared towards the relationship you're having with the pain itself, and being able to, in some way, have some kindness and self-compassion towards that, the self, or even the pain itself. So the thinking around this is a little bit different than traditional ways of mainly looking at coping skills and CBT. And then we also, thank you, and we also want to be able to have at a foundational level our ability to really help the individual go from different stages, or even just identify what stage of change they're in, how they can really balance the challenges of really engaging in treatment, or disengaging if it's opioid use, severe addiction, disengaging from treatment using motivational interviewing strategies, and being able to provide psychoeducation and pain coping skills training. And this is the pain coping skills training and education is really what was mentioned earlier by Dr. Wandner, where she was mentioning the biopsychosocial model, understanding the relationship, like, why is it that I get an intervention, I took these medications, and my pain doesn't go away? What explains it? Great opportunity. I think psychologists are really well versed in being able to answer these questions and educate patients, really. And understanding the gate control theory of pain, looking at how the brain really converts acute to chronic pain. And so in addition to that, really being able to also manage the comorbidities that comes with pain, like sleep, maladaptive eating patterns, weight management, and the fear of movement, which is listed here through the management of sleep and weight and vivo exposures. And then thinking about other interventions that help to really the person to shed light on what the difference between a part of them that's in pain and themselves, like internal family systems, and also bringing in couples and family therapy if it's indicated. And as Dr. Malcore was mentioning, when, in pain psychology, we may do pre-surgical evaluations, but sometimes the evaluation can serve as an intervention. And so there is this more of a emerging approach of psychological preparation for surgery. And as we know, the more individuals are psychologically prepared and have coping skills before the surgery, like spinal cord implantation, stimulation implantation, the more they have psychological preparation and skills before, the more likely they're going to do well after the surgery. So this becomes an intervention. And being able to also look at the technologies available to us. We are aware of the long research behind biofeedback, but also the newer approaches, functional MRI feedback, which of course it may not necessarily be feasible, but being aware of them and studies that are going on. And then self-help apps, which there are many now actually that integrate CBT and other approaches. And of course, using telepsychology, which we are all doing right now. And being able to think about this in a way where we have some sort of framework. There are many different types of frameworks that can bring in multiple interventions and help the clinician to decide, like, when am I going to do this? When will I do that? When will I help with pacing activities? When will I help with managing the catastrophic thoughts? When will I sort of understand what stage this person is in terms of motivation interviewing? There's many models. One is the behavioral medicine Y model. But being able to organize all this in a systematic way, which we give some examples in the paper. And I believe with that, I'm gonna hand it off to Dr. Ravi Prasad. Thank you.
All right. Thank you, Dr. Ramezani. Appreciate that. And so I'm going to round things out today with the fourth and final competency domain that we have. And what you'll all notice as you're hearing us speak is you'll see that these domains aren't necessarily mutually exclusive. There tends to be some overlap when we get from one domain into the next. And you'll certainly see that as we look at domain 4, which is looking at how context influences pain management. So the National Pain Strategy and Institute of Medicine emphasize the importance of attending to contextual factors as they influence pain. And we can look at contextual factors as they are categorized into 3 broad categories. Looking at social cultural background of patients and their families, looking at the characteristics of the community in which a patient resides, and then lastly, looking at the characteristics of the system in which a person's healthcare is received. And we're going to go through each of these one by one, starting with the sociocultural background of patients and their families. So when we're talking about the sociocultural background of patients and their families, we're really looking at all of the different contextual variables that affect that person, looking at age, race, ethnicity, gender, educational level, socioeconomic status. We know that all of these different factors have an impact on the pain experience. They impact a person's response to treatment, and they also have an impact on disparities. So for example, with race and ethnicity, We know that the different types of coping strategies that people use varies by race and ethnicity. We know that how people use the coping strategies varies, and the degree of efficacy with these also varies. We also know that there's variability in terms of education level in response to treatment. So for example, many of the treatments that Dr. Ramezani just spoke to us about, for example, the common cognitive behavioral therapy-based interventions, it's very common for the treatment to be delivered via an 8 or 10-week program where patients meet once a week over a 10-week period of time, and they learn about activity regulation, the role of stress management, breathing and relaxation exercises, things along those lines. But a lot of this curriculum might be delivered at a level that's beyond the scope of somebody who has a rudimentary educational level. The jargon that's used might be too complex for them. The figures might be too complex. So we need to make sure that we're paying attention to these different factors. And actually we have a great example of some of the work that one of our own colleagues did. Dr. Bev Thorne created a specific adaptation of CBT for pain, specifically for people that are low literacy, where issues such as jargon, graphics, things along those lines were addressed to try to make it more reachable for a wider audience. Socioeconomic status is another variable that plays a significant role. A lot of the things that we may take for granted, simple things like getting to and from a medical center for an appointment, having gas to fuel the car, having money to pay for gas, having money to pay for public transportation. For people that are socioeconomically disadvantaged, these are significant hardships that may preclude them from being able to access care. Now, in this current time, for this last year, in the COVID crisis, or the COVID pandemic rather, we've seen the advent of telehealth. Not necessarily the advent, but more the widespread use of telehealth. And some people may see that as, well, this is a great equalizer in healthcare, that now everybody has equal access to healthcare, even people that may be disadvantaged because of some of these things, such as finances, access to care. But the reality is, even with telehealth, we may still have some issues related to the socioeconomically disadvantaged. Some folks may have limitations on the number of minutes that they have on their cell phone plan. Some people may not have internet connectivity at home, which still puts them at a disadvantage where they're not able to access care. So we need to be hyper aware of all these different contextual variables within the patient's life and their family's life. Next slide, please. We also need to pay attention to the characteristics of the community itself in which the patient resides. We know that the responses that a patient gets from people in their society, people in their family, can influence a wide range of variables, including medication use patterns. It can affect health-related quality of life, affective distress, and pain-related disability. So for example, we know if a person gets punishing responses from people in their lives, from significant others, that tends to be associated with poor health-related quality of life, higher levels of affective distress, and higher levels of pain-related disability. Disability itself is a significant issue. There can be strong financial incentive for a person to maintain their pain condition. You know, there may be a release from an undesirable task. If a person doesn't have a very high level of job satisfaction, then the presence of their pain condition may preclude them from holding their job or doing their job. And so that could be a reward in and of itself. Also, if a person's getting strongly solicitous responses from their family members, that may also be something that reinforces maintaining that disability. And it's important to note that some of these factors can either be from the pain or from the treatment that person's receiving for their pain condition. So a person's medication regimen, if a person's a heavy equipment operator, their medication regimen may preclude them from doing their job responsibilities of operating the heavy equipment. A person who may have a spinal cord stimulator implanted may not be able to engage in certain physical aspects of their job out of fear of lead migration. So it's not just the pain condition, but it may also be the treatment that a person's receiving for their condition that can influence disability. Next slide, please. And the last thing that we need to pay attention to are the characteristics of the system in which a person's receiving their care. Here, we need to be aware of the different types of pain. There's acute pain, chronic pain, end of life issues, cancer-related pain, and all of these different things may have different nuances associated with them. So for example, if you're doing neuromodulation evaluation, looking to have a stimulator implanted in somebody who's got a chronic pain condition versus somebody who's got cancer pain, and you're looking at palliative care, what are the differences in those evaluations? Are there differences? And it's important to be able to understand those different factors. It's also important to understand all of the different players, all the different people that are involved in the delivery of pain care. Who are the different clinicians involved in pain care? What are the different disciplines? How do they differ from one another? What's the role that they play, or the different roles, plural, that they play in the person's treatment? And what's the scope of practice that each of these different clinicians have? You know, I've always said that it's important for each clinician on the team to have a good, solid understanding of those different roles. So for example, in a team that's comprised of a physician, physical therapist, and a psychologist, it's important for the pain physician to have a solid understanding of pain physical therapy and pain psychology. It's important for the pain physical therapist to have an understanding of pain medicine and pain psychology. And it's important for the pain psychologist to have an understanding of pain medicine and pain physical therapy. Not because any of us are going to go out of the scope of our practice, but rather so that we can reinforce the messages that the other person is telling the patient, so that we can really deliver that true interdisciplinary care. We also need to be able to use technology to help communicate care for patients using an electronic medical record. But we also need to make sure that that communication is effective and parsimonious. You know, in a busy day, if you're communicating a message to a primary care clinician who has 10 minutes to see each of their patients, and they've got a full docket, the last thing that they want to do is read a 6-page pain psychology evaluation. So we want to make sure that we're able to communicate things very effectively in as few words as possible that communicate the gist of the message and all the pertinent positives. And lastly, we need to be able to advocate for the care of our patients. And this goes beyond just doing things like trying to advocate with insurance companies and such to make sure that patients are able to receive care, but also within our healthcare teams themselves. You know, if we feel that a patient is being over-medicalized, over-proceduralized, it's important that we're able to advocate for that patient's care in a respectful and appropriate manner with our team. So the next slide, please. So this basically rounds out our 4 different domains of the core competencies. But we want to present this to you because there's a renewed interest among healthcare professionals in non-pharmacologic approaches to pain management. And even though this has been present for a long time, the interest was sparked again by the opioid crisis that we found ourselves in this country. Fortunately, we've seen some shifts with the opioid crisis. We've certainly seen that the fatality rate has decreased, but pain continues to be very pervasive in this country. And thus, psychology and other non-pharmacologic interventions are going to continue to have a high level of relevance and a high level of visibility in our healthcare landscape. All of us that are presenting today think it's important to identify the core fund of knowledge that's necessary to guide the work of psychologists in this arena. And the aim of our presentation today, as well as the article that we published before, was to serve as a catalyst to start communication about this. What are the different types of things that are necessary to identify pain psychology? As Dr. Kearns mentioned, even the term pain psychology was coined by physician groups. But what does it mean to be a pain psychologist? And we're hoping that this discussion in our paper will serve as a catalyst for those discussions. And lastly, we have a number of resources here just to try to help those of you that are working in the field of pain, resources for both clinicians and resources for patients, or those individuals who are living with pain, people treating those individuals living with pain.
Thank you to all of our presenters. I really want to show my great appreciation again to the 2 societies for offering us this opportunity. I'd like to encourage anybody with questions or really comments, reflections on what was said today to put them in the chat, because we don't have the opportunity for kind of open mic, and we'll try to address those as they come in. Somebody's suggesting to put the resources in the chat so that they're more available. I think the slides, by the way, will be posted and available afterwards, if I'm not mistaken. But let's see if somebody, maybe Claire or Barbara, could put them in the chat. And then I think there's another question here. Hello to all. With multi-factor pain intensity, how assessment and approach to management is determined based on condition, illness. I'll just take a stab at that. I think my own view about this is that it's incumbent upon, I would like to encourage an approach where every psychologist, regardless of the setting in which they work, regardless of the presenting complaint of their patient or client, screens for the presence and intensity of pain. And I'll elaborate on that in just a minute. My own view is that when pain is present to a significant degree and in partnership with the patient, that can prompt the beginning, at least, of a more comprehensive pain assessment that includes consideration of the person's experience of pain and their history, but also an effort to gain information about what current treatments they're engaged in and what other treatments they've had in the past, potentially including requesting signed releases to be able to communicate with other current providers and obtain records and open dialogue in the service of potentially establishing a team to work with the patient at the center of that team, and that assessment should inform then an integrated treatment plan, which may involve a very limited focus within the context of the treatment or the request from the client who comes to you for example, marital therapy or depressive therapy. It may, the focus on pain may not be as high priority for that person in the context of your treatment, but it may actually be important for many other reasons. So my own view about this question really is to kind of think about assessment and then think about pain intensity assessment as just one part of both a continuum toward the development of an integrated plan of care, and only one important, but not necessarily even the central component of a pain assessment that may be much more on focused on understanding a patient's values and goals for their treatment, understanding how pain is perceived by them to be interfering with their life, their physical and emotional functioning, their social role functioning. So the pain intensity itself may not be a particular driver, but of course, an important part of the assessment. I hope that addresses the question a little bit. I think there are a couple more questions in the chat. Could one of you provide an update on efforts to develop a new interdisciplinary pain organization? I'm happy to say that in this country, recent efforts of colleagues after the demise of the American Pain Society has led to the development of a new multidisciplinary organization called the United States Association for the Study of Pain. It's the official American or US affiliate of the major international organization in this area, the International Association for the Study of Pain. For more information about that, you can contact me, but I think the website is pretty easy to access. It's the US ASP, or US, I think, _ASP, should get you there. I hope that answers that question. Oh, okay, and Laura put it in the chat. Back to the question of really our objective 3, why this is important, why we think this is important. I've kind of alluded to it already, but let me elaborate. In a recent viewpoint or commentary in JAMA Psychiatry, colleague of mine, Sarah Edmond, and Alicia Heapy and I wrote a commentary, a viewpoint, really calling on all mental health providers to pay attention to pain and to bring pain, a discussion of pain, into their at least initial conversations with virtually any client. Why is that important? I've already emphasized that pain is a serious public health problem. If 50 million Americans, 28% of the adult Americans experience chronic pain, and we know that pain is highly comorbid, co-occurring with virtually any Axis 1, even Axis 2 mental health diagnoses, as well as many other medical conditions. It's very likely that a majority of the patients that you are seeing, regardless of their presenting complaint, have chronic pain and maybe even significant chronic pain that is affecting their daily functioning. Evidence from decades of research has documented that pain is a significant moderating factor for the treatment of depression, including the benefits of antidepressant medication therapy, as well as psychological treatments for major depressive disorder. And the same is true with post-traumatic stress disorder, anxiety disorders, and substance use disorder, especially alcohol use disorder and opioid use disorder, which are particularly prevalent among this population. So if that's the case, then it seems it really quite important to at least ask about pain, to understand the person's experience of pain and how it potentially interfaces with their presenting complaint, and to think about how it could be better addressed, both within your therapeutic approach for the presenting problem, and or via efforts to help assist your client or patient in obtaining appropriate access to care from other healthcare professionals.
And
it looks like you want to jump in.
Yeah. I'm glad you brought up so many excellent points, and I hopefully no one is thinking this at this point, but I've talked to people and they'll say something like, well, I don't work with patients who have chronic pain, or pain isn't something my patients or I are concerned with, and I really think we want to drive home that point that we wouldn't recommend that. We would recommend that you reconsider that assumption, right? So we've already kind of alluded to some of this, but the information from the National Health Interview Survey estimated about 1 in 5 adults in the United States had chronic pain. And so really, again, given the estimated rates, how likely do you think it is that at least some of your patients have chronic pain? And we've also discussed earlier some of the potential impacts of pain. And I think that this is a really excellent example of where our patients may not know what services mental health providers or professionals can provide them. And if you don't provide that window, I think it becomes a missed opportunity.
Thank you, Sylvia. I noticed one other, before I move on to other comments from our panel, I did notice one other question in the chat about hypnosis, entirely an oversight. I don't think we listed our intent was not to list all evidence-based psychological or relevant approaches. But let me just make a point about hypnosis, that in fact, of course, it has a long history of use in the management of pain, and continues to have a growing evidence base to support it, including some really prominent investigators in our field who have published some relatively recent, very high quality research on the role of hypnosis and similar approaches, maybe label them self-regulatory approaches, but I do thank the person for putting that in the chat. There was also a question about journals for people in the area to look at, and potentially as targets for for manuscripts for publication in this area. There are many. There are no shortage of outlets besides our own journal, Health Psychology, which has a significant place in this space in terms of publishing important science and scholarship related to pain and pain management and pain psychology. Other journals in our in health psychology, behavioral medicine are of course appropriate target. In terms of specialty pain journals, the International Association of the Study of Pain journal is considered by many the premier outlet with a very high impact factor. That's the journal Pain. It's published monthly by ISP. There's also the USASP's journal, which they recently purchased, and that journal's name is Journal of Pain. It's also a very high impact journal, probably just under Pain. And then two other journals, but not to be exclusive. I guess there's a risk of always naming journals, but two other maybe more clinically relevant journals are the American Academy of Pain Medicine's journal, which is called Pain Medicine, which is very favorable to psychological research in pain and pain psychology, and also the Clinical Journal of Pain, an oldie but goodie. It's been around for decades. I'd say interestingly, but maybe not surprisingly, but Pain, Journal of Pain, and Clinical Journal of Pain are the editor-in-chief of each of those journals are psychologists. And in the multidisciplinary organization, USASP, psychologists are the second largest group of members of that organization. And several of the presidents of those organizations like USASP and ISP have been psychologists as well. Back to our, I guess there's more questions in the chat. Let's see.
Just keeping an eye on the clock, we probably have time for one more question.
All right. Important work on opioid tapers. I think that's a great, important point. So there is, a gap in our scientific and clinical practice literature to guide safe, patient-centered opioid tapering when it's indicated. There's a reference here to the Empower study by Beth Darnell, but there are also other important projects, some of which I'm involved in, that are being conducted as we speak, and that, by the way, incorporate the role of psychologists and psychological counseling or therapeutic approaches in that context. But there's a lot of work that's necessary to be done on that.
And Bob, just to jump in on that last one, NIH currently has a funding announcement out right now to look for studies that are treating comorbid chronic pain and opioid use disorders. So we are right now at NIH in the process of recruiting new studies to look at this, as well as PCORI. PCORI also does a lot of really wonderful work, which is funding Beth Darnell's work on opioid tapering plans. So there is good research out there, but we are also recognizing, as Bob says, there's a gap, and we are currently in the process of recruiting new studies to address those gaps.
Ravi, it looks like you want to if you make some closing remarks, that'd be great.
Sure. Just a number of things that I wanted to comment on just related to some of the work that APA is doing. There is one question in the chat about guidelines, and actually APA does have a group that's together right now that's working on guidelines for musculoskeletal pain. The group started last year. I'm on that committee, and we're still in process of working on developing those guidelines. So that will be something that comes out in the future. But related to some of the work that we're talking about today in terms of education for psychologists who are practicing in the field and the importance of understanding pain. APA has recognized the importance of this, and they've developed an educational workshop that's meant to provide fundamental pain education for all psychologists. They first delivered the workshop in conjunction with the Ohio Psychological Association in 2020. This was in combination with the legislative day in which APA leadership met with state legislators and their representatives to advocate for increased coverage for behavioral health psychological services. This is also presented at APA's state leadership conference to allow state leaders to experience the workshop so they could then advocate for bringing the training to their respective states. COVID-19 precluded us from being able to deliver that live in person, but already there's been some states, I think we're scheduled to do it in Oklahoma in April, and Iowa in October later this year, doing virtual presentations. And APA is in the process of creating a recorded version of the workshop so that this can be delivered through the state's state association. So APA has a vested interest in trying to provide this education as well and doing what they can to make that happen.
Well, I want to thank everybody for your participation today. I want to especially thank our group of panelists. I do want to make a specific shout out to Laura Wandner, who led our paper in American Psychologist and who really took the leadership role in helping organize this symposium. I'm very proud of our work. Please, if you have additional questions, we're all available to answer them offline. Please, it's easy to find our email and communicate with us as a follow-up. And again, thank you all for your interest and participation.
Just a quick reminder, thanks again for attending. I'd like to echo what Dr. Kearns said. Remember, if you'd like CE credit for attending this event, please respond promptly to the evaluation link, which will be sent via email very shortly. Again, we'll leave the evaluation period open until April 2nd, and CE certificates will be sent via mail, or email, not mail, email, within 5 to 10 business days after the evaluation period closes. Thank you.